Hi, my name is Dr. Jasdeep Mathru. My close friends and family call me Jazz. I'm a new pulmonary critical care physician at Lourdes. Just moved here from Florida at the end of June. I've just started my practice. I was born and raised in Vancouver, British Columbia. My parents immigrated to Canada from northern India in the 60s. They came as engineers, and I turned out to be the black sheep in the family and became a physician. What made me go into medicine? My two undergrad subjects were biochemistry and physiology. Very exciting. It's cutting edge technology. Nothing more exciting than knowing how the human body functions and what makes it sick. The obvious pathway was to get into medicine and put those two favorite subjects together with the love of being with people. That's what brought me to medicine. I did my undergrad at Simon Fraser University in British Columbia. Also did a physiology biochemistry major at University of Saskatchewan in also Canada, and then went over to private medical school at St. George's University in Grenada. Did my clinicals in New York, and then ended up doing my residency and fellowship training all at the University of Florida and at the Mayo Clinic. My biggest influences have always been my parents. My parents have been everything for me. They're immigrants from India. They moved to Canada in the 60s. They worked hard their whole life and made nothing into something. My largest motivator has been my wife. She's been with me every day through my entire training career. She's been supportive. She's given me two lovely children. I have a lovely 9-year-old daughter and a 5-year-old son. And for me to come home on time in this area here, to have that kind of time with them, is priceless. That's the biggest reason I moved out to the Tri-Cities. The Tri-Cities, I love the Tri-Cities. It's a nice, quiet place, decent place to raise children and more time for them. Coming from a giant 700-bed hospital with a 100-hour work week, this is way better. Trust me, way better. Lourdes is a wonderful organization. It's quite an amazing experience when you walk through the door and you can see the CEO of your hospital rounding on the patients in the hospital. On the other side, you can see one of our beloved sisters, Sister Esther. She's also rounding on the patients. Just to go through the hallways and to see that level of care and love for a patient, I feel good there. I don't feel like I'm there doing anything else except medicine. It's a very loving place, very caring. From interview process to hiring, these folks are wonderful, very forthcoming, very honest. I think my practice at Lourdes is unique and interesting, given that my patient is very unique. The folks that come to a pulmonary practice have been already seen by internal medicine. They are very complicated. Their biggest concern is that they can't breathe. You can't talk about the lungs unless you know the entire body system, be it the cardiovascular system, be it the immune system, be it whatever. But when they come and they can't breathe, it is my job to figure out why they can't breathe. Coming from a large university center that is able to diagnose and treat lung cancer, often the cost is forbidding to make those diagnoses. I've been trained at the University of Florida and at the Mayo Clinic for transplant and for lung cancer diagnosis and screening and diagnosis, and am able to bring that technology here. Folks won't have to go far to either Spokane or Seattle to get this diagnosis. The diagnosis can be done here in a matter of a day. What makes our practice unique at Lourdes Pulmonary is the recent acquisition of an endobronchial ultrasound. This is better known as EBUS. Normally this type of equipment only exists at large university centers and large tertiary centers. Currently, patients who need diagnosis for lung cancer have to either go to Spokane or Seattle or other large centers. Fortunately, I've been trained in this technology and will be able to provide this service here at Lourdes. It's just a matter of you go in, you come in the morning, we make you sleep just by the usual way. I put a scope down into the throat and into your lungs and find an area of interest that I've seen on a CAT scan prior. At that point, I would pass a very fine needle through that scope under ultrasound guidance. Before it was done blindly, but now I can see exactly where the tumor or mass is, or density, because not all densities are cancerous, able to pass a fine needle through there and suck that tissue out and send it to the lab for early diagnosis. Traditionally, this is usually done by a surgeon. They put a small hole in the neck, and then they go into the chest with this larger scope. That requires sometimes staying overnight in a hospital. It also requires general anesthesia and sometimes not everybody's well enough to go under anesthesia. This is a simple in-clinic procedure, and you'd be going home the same day. Hi, my name is Dr. Jasdeep Mathru. My close friends and family call me Jazz. I'm a new pulmonary critical care physician at Lourdes. Just moved here from Florida at the end of June. Just started my practice. I did my undergrad at Simon Fraser University in British Columbia. Also did a physiology biochemistry major at University of Saskatchewan in also Canada. And then went over to private medical school at St. George's University in Grenada. Did my clinicals in New York, and then ended up doing my residency and fellowship training all at the University of Florida and at the Mayo Clinic. July 2013, the USPTF came out with guidelines for lung cancer screening, low-dose CT scanning. This is going to be an excellent tool in the early diagnosis and treatment of lung cancer. Right now, we usually find lung cancer at its later stages. Now we have a tool to find these nodules early. Fortunately, we have technology available to us like the endobronchial ultrasound to get a hold of all those peripheral nodes. Hilar nodes, subcarinal nodes are easily accessible by an endobronchial ultrasound. I'm able to pass a scope down just like a regular bronchoscope, but at the tip there's an ultrasound piece. The mass or density or the lymph node can be visualized, and through there transbronchial needle aspirations can be done for early diagnosis. Fortunately, most